Today, inshallah, we'll talk about how to interpret ABG, arterial blood gas. As we know, through the arterial blood gas sample, we can assess the acid-base status through pH, PCO2, and the bicarbonate level. We can assess ventilation through the CO2 concentration. We can assess oxygenation through the oxygen saturation and BO2. And of course, acid-base disturbance may lead to serious electrolyte disturbance. These are the normal values. The pH is 7.35 to 7.45. BCO2 is from 35 to 45 millimeter mercury. BO2 from 80 to 100 millimeter mercury. Bicarbonate 22 to 26 milli equivalent per liter, and oxygen saturation from 95 to 100%. Okay. The first step to interpret ABG is using the pH to determine whether it is acidosis or alkalosis. The pH, if it is normal, 7.35 to 7.45, it is normal or compensated. Depends upon bicarbonate and CO2. If both of them are normal, it is normal pH. If one or both of them is abnormal, it is a compensated pH. And as we know, the alkalosis means pH above 7.45, and the acidosis is below 7.35. The second step is to look for CO2 concentration. The normal is 35 to 45 millimeter mercury. If it is elevated, this tends towards acidosis. And these are the causes of increased CO2 concentration, which is decreased ventilation due to sinus depression, pleural disease, COPD, acute respiratory distress syndrome, musculoskeletal disorders, or compensation from metabolic alkalosis. If it is reduced, this tends towards alkalosis, and these are the causes of respiratory alkalosis, which is mechanical overventilation, increased intracranial pressure, sepsis, hypoxia, hyperpyrexia, heart failure, anxiety, asthma, ascites, and other causes. So the first is to look for pH to determine whether it is acidosis or alkalosis, and the second step is look for the CO2 concentration. If the CO2 concentration can explain the disturbance in the pH, it is respiratory disorder. If it does not explain, it will be metabolic disorder. Like in this example, the pH is 7.35, it is normal, and the CO2 is normal, so it is a normal arterial blood gas sample. Look at this one. The pH is 7.2, it is reduced, this is acidosis, and the CO2 concentration is elevated, so it is a respiratory acidosis. Here the pH is high, so it is alkalosis, and the CO2 is low. Low CO2 can explain the alkalosis, so it is a respiratory alkalosis. This is acidosis and the CO2 is low. CO2 is low does not explain acidosis, so it is metabolic acidosis. And this example, the pH is high and CO2 is high, so it is metabolic alkalosis. So to summarize, if you find the pH is low and bicarbonate is low, this is metabolic acidosis. If the pH is high and the bicarbonate is high, it is metabolic alkalosis. If the pH is low and CO2 is high, it is respiratory acidosis. And if the pH is high and CO2 is low, it is respiratory alkalosis. And we can summarize it in the word of ROM. ROM means respiratory opposite and metabolic equal. Let's start by metabolic acidosis, as we will concentrate on only metabolic acidosis and alkalosis, because the respiratory disorders will be discussed or will be studied in the section of chest diseases. Okay. If you diagnose a case of metabolic acidosis, the second step is to calculate the anion gap. The anion gap equals sodium minus the sum of chloride and bicarbonate. Okay, so it is the normal value of anion gap, serum anion gap, is 12 plus or minus 2 or plus or minus 4, so we can expand the range from 8 to 16. What's this anion gap? As we know, anion is the negative charged molecules and the cations are the positive charged. From the name, it means that we have a defect in the anions. Cations are more than anions. It is a misnomer. It is a mathematical gap. It is not a true gap. Okay, And this can be explained in this figure. Sodium 140, chloride 15, and bicarbonate is 25. Okay, if we calculate the anion gap, it will be 10. This 10 can be explained by some anions that are not measurable and don't enter the equations, and most of them is album. Okay, so this is the source of the anion gap. And it is like in this example, the anion gap is 12. It is a normal. It can be explained by mainly by the album. Let's look at this example. It is a case of lactic acidosis. If we calculate the anion gap, it will be 140 minus 13 plus 15. It will be 22. So the anion gap is increased because there is a reduction in the bicarbonate by 10 due to accumulation of 10 millimole of lactate, and the lactate does not enter the equation, so we will have an increase in the anion gap. And this is high anion gap metabolic acidosis, and these are the causes of high anion gap metabolic acidosis. They are methanol toxicity, uremia, diabetic ketoacidosis, baryl diatoxicity, iron INH toxicity, lactic acidosis, ethylene glycol toxicity, and salicylate toxicity. Okay, let's look at this example. Here the bicarbonate is reduced by 10 from 25 to 15, and the chloride is increased from 130 to 113. So if we calculate the anion gap, it will be the same, and this is normal anion gap metabolic acidosis or hyperchloremic metabolic acidosis. And these are the causes, and the two main causes for these disorders are renal tubular acidosis and diarrhea. So again, to summarize, the first step is to determine which type of acid-base disorder according to the pH value and the PCO2 value. Okay, if we diagnose the case of metabolic acidosis, the next step will be to calculate the serum anion gap, and we have two possibilities. It can be either high, this is high anion gap metabolic acidosis, and its causes are mud biles, and it can be normal, and the two main causes for the normal anion gap metabolic acidosis are renal tubular acidosis and diarrhea. Okay. How to differentiate between renal tubular acidosis and diarrhea? By measurement of what's called urine anion gap. The urine anion gap equals sodium plus potassium minus chloride. If it is negative, like -1, -2, -3, this is diarrhea. If it is positive, +1, +2 or more, it is renal tubular acid. Let's look at this diagram. This diagram for the compensations. If you have any type of disorder, there will be compensation by the other organ. But today we talk about metabolic disorder, so we will talk about the respiratory compensation. Let's look. For metabolic acidosis, the initiating mechanism is decrease in bicarbonate, and the expected pulmonary response is decrease in the CO2 concentration. How can we calculate the amount of reduction in CO2? By this equation. The decrease in CO2 or delta CO2 equals 1.2 by delta bicarbonate. 1.2 by delta bicarbonate, and we will have examples to know how to calculate this issue. Regarding metabolic alkalosis, the initiating mechanism is increase in bicarbonate, and the expected pulmonary response is increase in CO2. What is the amount of increase? Equals 0.7 by delta bicarbonate. Okay, so don't forget this table for compensation, very important. Okay, before we start to solve examples or to answer examples, we should know the median values of everything. The median value for pH is 7.4. The median value of bicarbonate, to use it if we calculate the bicarbonate, delta bicarbonate, it is 24. The median level of CO2 is 40 and anion gap is 10. Don't forget these figures. Okay, let's start by the first example. In this case, the pH is 7.32, bicarbonate is 15, CO2 is low, sodium and chloride. Which type of acid-base disorder? We have a low pH and low bicarbonate and low CO2, so this is metabolic acidosis. Okay, And if you calculate the anion gap means sodium minus the sum of chloride and the bicarbonate, it will be 10. It will be 20. So this is high anion gap metabolic acidosis. Okay. The next step is to look for the respiratory compensation. Okay. What do you expect for CO2? We expect CO2 is to decrease. What is the amount of reduction? The delta CO2 equals, from the previous table, 1.2 by delta bicarbonate. We calculate delta bicarbonate from the median value, which is 24. So it equals 1.2 by 9. So you expect CO2 to decrease by 10.8 millimeter mercury, or 11 millimeter mercury. So the expected CO2, the median is 40, and you expect it to be reduced by 11. So the expected is 29. It is more or less the same. So this is high anion gap metabolic acidosis with appropriate respiratory compensation. Okay. Let's look at the next example. pH is 7.2 and CO2 is 40 and bicarbonate is 15. Okay. So the pH is low and the CO2 and bicarbonate is low. And we can calculate the anion gap. It will be the same. It will be 20. So this is high anion gap metabolic acidosis. Okay. Let's go to the next step, which is calculation of the respiratory compensation. Again, delta CO2 equals 1.2 by delta bicarbonate. This is like the previous example. So the expected CO2 is 29. But here it is 40. So there is retention of CO2. So this is a mixed disorder. It is a mixed high anion gap metabolic acidosis and respiratory acidosis. Okay. Let's look for the next example. The pH is 7.4. So it is normal. Again, if the pH is normal, look for CO2 and bicarbonate. If they are both of them is normal, it is a normal ABG. If one or both of them is abnormal, it is a compensated disorder. Okay. So in this example, the CO2 and bicarbonate are abnormal. So it is a compensated. And here you can either start by compensated respiratory alkalosis or compensated metabolic alkalosis, because the pH is in the median value. Okay. If the pH is above 7.4, we'll start by the alkalosis. If it is below 7.4, we'll start by the acidosis. Okay. So we will start it as a compensated metabolic acidosis, and the anion gap is high. So this is a compensated high anion gap metabolic acidosis. Let's calculate for the respiratory compensation. Again, 1.2 by delta bicarbonate, the same. The expected CO2 is 29 and it is here 25. So there is extra CO2 wash, okay, or hyperventilation. So this is a mixed high anion gap metabolic acidosis and respiratory alkalosis. Okay. Let's look at this example. The pH is 7.6. BCO2 is low, bicarbonate is high. So it may be either metabolic alkalosis or respiratory alkalosis. And I prefer to start with the metabolic disorder because of the simplicity of calculation of the respiratory compensation. So we'll start as a metabolic alkalosis. Okay. Let's look for respiratory compensation. Here, the respiratory compensation is increase in CO2, not reduction in the CO2. What is the amount of increase? It is 0.7 by delta bicarbonate. Okay. The delta bicarbonate, we measure it from 24. So it will be 0.7 by 5. 3.5, so the expected CO2 is 43.5 and it is here 30. So there is a CO2 wash. So this is a combined or mixed metabolic and respiratory alkalosis. Again, the issue is very simple. You should start in stepped manner. You start by knowing the acid base of the acid base disorder. And in this lecture, we focus on the metabolic disorders. If you diagnose metabolic acidosis, you should determine which type, high or normal. Okay. If it is high, it's okay. Normal, you should do the urine anion gap to detect whether it is diarrhea or renal tubular acidosis. Okay. If you diagnose a metabolic disorder, you should look for or you should calculate the respiratory compensation. In metabolic acidosis, the expected CO2 is to decrease, and in metabolic alkalosis, you expect CO2 is to increase. You should know how to calculate the delta CO2 in both types, and through this you can determine whether it is a single or simple metabolic disorder or combined with respiratory disorder. Okay. Another issue is how to diagnose a metabolic alkalosis. If you diagnose a metabolic alkalosis, you should measure the blood pressure and detect the hydration status. Okay. If they are low or normal, you should measure the urinary chloride. If it is increased above 20 millimole per liter, this can be induced by diuretics, Bartter-Gitelman syndrome, or hypomagnesemia. If it is low, this means extrarenal loss, like vomiting, nasogastric suction, sometimes recent diuretics, or post-hypercapnia. Okay. If the blood pressure or hydration status are high or normal, you should check for the renin activity and aldosterone. If the renin is low and the aldosterone is high, this is primary hyperaldosteronism. Maybe adenoma like Cohen syndrome, bilateral adrenal hyperplasia, or carcinoma. If both of them are high, this is secondary hyperaldosteronism, like malignant hypertension, renin producing tumor, renal artery stenosis. If both of them is low, this is a case of apparent mineralocorticoid excess, like Cushing, licorice, Liddle syndrome, or some enzymatic deficiencies. So this is the approach for diagnosis of metabolic alkalosis according to the blood pressure and hydration status. Okay. Another issue is how to diagnose hyponatremia. The diagnostic approach for hyponatremia also should assess the volume status, and you have one of three possibilities. It's either hypovolemia, eovolemia, or hypervolemia. If it is hypovolemia, you should measure the urinary sodium. If it is high, this is a renal loss, like diuretic excess, mineralocorticoid deficiency, or salt-losing nephropathy. If it is low, this is extrarenal, like vomiting, diarrhea, and third space loss. If you have an eovolemia, no edema, it may be induced by drugs or endocrine disorders. The endocrine disorders are glucocorticoid deficiency, hypothyroidism, and syndrome of inappropriate and diuretic hormone secretion. The three drugs are cyclophosphamide, carbamazepine, and clofiprid. So again, if you diagnose a hyponatremia with eovolemia, it may be caused by endocrine disturbances like glucocorticoid deficiency, hypothyroidism, or syndrome of inappropriate and diuretic hormone secretion, and three drugs. If you find the hypervolemia, you should measure the urinary sodium. If it is high, this is a renal injury, either acute or chronic kidney injury. If it is low, it is nephrotic syndrome, cirrhosis, and heart failure. So again, the approach for diagnosis of hyponatremia should depend on the volume status. The evaluation for hyperkalemia, it is very important. You should check for ECG, you should check pseudo hyperkalemia, you should do evaluation for everything: history of dietary intake, obstructive uropathy, is metabolic acidosis present, hyperosmolarity, if the patient is taking any potassium raising medications like potassium sparing diuretics, S inhibitors, ARPs, and you should of course check for the kidney function, and you will deal with emergency if the patient is or have ECG changes by giving the necessary medications. So in this lecture, the main topic of it was the interpretation of arterial blood gas sample, and again we should assess through the pH, PCO2, and the bicarbonate, and you should pass in a stepped manner, and then we pass the two briefly the approach for diagnosis of metabolic alkalosis, hyponatremia, and how to deal with hyperkalemia. Finally, thank you and wishing you good luck. Thank you. Lastly,